Well, good morning. Nice to see you this morning. And for the second part of what we're doing, for those of you who weren't here the first day, I'll introduce myself. My name is David Sherbino. I've been working in this field of grief and bereavement, death and dying for a long time. I'm a professor at Tyndale Seminary. I'm also a minister with about 40 years of leading a congregation. And so in my journey, I've obviously conducted many funerals. I've walked with people who are dying. And now the challenge is, how do we help people who are grieving and dealing with all kinds of different losses in their life? If you want to be, excuse me, I got something in my throat. If you'd like some further information, at Tyndale, we have developed a Center for Grief and Loss. And there are many programs that are offered online. You can join in, if you want to do a 2-hour seminar. We do a lot of these on Saturdays or sometimes in an evening, about 2 hours. And it helps people to have a better understanding and to equip them. And so it becomes a very easy way of doing it. For some of you who want to be more adventurous, we're the only university in Canada that offers an MA and a doctorate in this field, where we train you to actually become a therapist working with people who are dealing with grief and loss. So there's a wide range of things available. All you got to do is look under www.tyndale.ca. You will see the programs and look for we have a number of centers. So the Center for Grief and Loss, or just Google that in and it will pop up, and it will tell you everything that's happening in the fall, the winter, the spring, the summer. Gives you an idea of what's available. Well, today, I'm going to talk about some of the things at the end of life. And there are so many facets that we could actually cover in this area, but I'm going to try to give you just a couple of major issues that I see are confronting the Canadian landscape as we negotiate a death. And we're talking about that term, negotiating death, because that's the reality we are living with advanced medical technology. This is the new reality. People are saying, I have a lot more choices, like how do I want to die? Even when do I want to die? And we're going to see that a little bit later with the whole idea of MAID, which means medical assistance in dying. In the past, when people were gravely ill, the illness just kind of took its course and eventually people died. And so with the technology we have today, we're able to prolong life. Or the question we have to ask is this: am I prolonging life or am I lengthening the dying process? And to me, that's an important distinction to make, because you're going to have to make all kinds of decisions about your life, as I have to make them about my life and how it's going to begin to unfold. In Canada, in the census taken in 2016, which was 10 years ago, the average age of people living was 82.3. It's higher for women than men, but by the 2030, men will be living till about approximately 84 years of age, and women to about 87 years of age. Now, years ago, many people died much younger because we didn't have all the advances in medical technology, we didn't have all the antibiotics, we didn't have all the resources available to us in healthcare. And so many are living a lot longer, and many people are dying a lot slower. And that's just the reality of life. So when we talk about having a negotiated death, there is a presumption that I want to have complete control over my life, and I will even choose for when I am going to die. Now, we know that doesn't always happen. You could be killed in a car accident. You weren't intending on that to happen. You could have a massive heart attack, and that was not of your choosing either. So one of the questions we're going to have to face are some of the ethical issues that are in front of us. And I would say that from a Christian point of view, we need to look at two passages in Scripture to help us to make some of these decisions. The first passage is something very familiar, which is the 10 Commandments, found in Exodus 20. Now, what does it mean that thou shalt not kill? Do I have the right to take my own life? The second passage is found in Matthew 22, and this is where Jesus talked about love God with your heart. I put it this way: love God with the totality of your being, mind, heart, soul, and strength, and your neighbor as yourself. So this becomes the reality that we are going to be dealing with. So I want you to keep those two ideas in mind as we look at some of the ethical decisions that have to be made. The 10 Commandments, and then Jesus summarizing all things in loving God and loving your neighbor as you love yourself. So what has become familiar to a lot of people is this statement called euthanasia. And now, when you think about it, it comes from this Greek word, eu, which means well or good, and thanatos, which is the idea of death. So that's why I have a background in thanatology. Now, when I tell people that I'm a clinical thanatologist, they have no idea what I'm talking about. Like, have I come from another planet? Just because we haven't used that language so often. But if I say I work with grief and loss, oh, now I get it. So we're going to be focusing today primarily on death. But as I mentioned on Tuesday, there are at least 45 other types of losses that people will deal with. Whether, as I mentioned, it could be the loss of a marriage, through divorce. It could be the loss of your job, employment. It could be the loss of your social status. It could be the loss of your hopes and dreams. The list goes on and on. But we always grieve our losses. And so that becomes the reality that we need to be aware of. Now, we have been aware of euthanasia for a long time, and that happens in a variety of settings. So I want to break it down into 4 basic categories of euthanasia. The first one is what we call voluntary, and that is I, as an individual who is rational, I'm thinking straight, I have mental competency, I make a decision that I wish to end my life. Now, that decision might include a medical team that will help me to die. But there could be involuntary. And involuntary, this is when I would be perhaps in a comatose state. I am not legally competent to make decisions for myself, but there's an agreement reached upon by maybe my immediate family or a legal guardian and the medical team that it would be best to end my life. Now, tied in with that, we have what is called active and passive euthanasia. Active this is the commission or the enactment of a positive act that will end a patient's life. And most often it is done by a drug. So a lethal injection will take place. Or some people might say, we're going to withdraw medical care. That would not be active. We would see that as being passive euthanasia. Because if I disconnect the respirator that is keeping me breathing, for example, it allows the patient to live or die as a natural consequence of the disease or injury. We're just taking them off the machines that are keeping them alive. And this is why passive euthanasia is really letting the patient die without treatment. So they might say, I wish to have no more treatments. I've gone through enough. I don't want to go through another series of whatever it's going to be. Just let me be. Or if a person is dying and they have terminal cancer and maybe they get an infection, they would refuse antibiotics because it's just going to keep them alive a little bit longer because the cancer is going to be the cause of their death. Or it could be we are going to choose to stop treatment. This is when it is determined that the treatment is no longer of benefit to the individual, and the patient is allowed to die receiving comfort or care. Now, as a minister, I have had congregants who have been in that state in the hospital, and the family have called me up. And I think of a situation that just happened a while ago. They called me up, and I knew this man. He had had a number of health issues for a number of years. He was only maybe in his late 60s, but his health had been badly deteriorating, and he had gone into a state almost like a comatose state. He had been kept alive on life supports for a week, and every time they started to move the reduce the support of care he was getting, all the numbers would go down. The family called me in and said, "We're wondering about Dad, what we should do. Do we take him off life supports? If we are we not taking his life?" Now that's a really tough question. And some of you are going to be in that state of making those decisions, or your children might have to make those decisions for you. I look at my life, I have adult children, 2 adult sons. Maybe at some point in time they're going to have to make that kind of a decision about me. And so we talked about it, and by stopping the treatment, we were allowing natural death to occur. That was the trajectory. And I think sometimes we have forgotten the words of Ecclesiastes. There's a time to be born, but there's also a time to die. And I think about this from a Christian point of view. Death isn't the end. In fact, God says something far more glorious is awaiting those who know and love him. But I understand why people don't want to let their loved one go. We have that emotional connectedness with that person, and they're no longer going to be in our life as they once were. Remember, I told you the story of the little boy found dying, who had drowned on the seashore. Though I had a sense of sadness, I didn't know that child, but the parents knew him, and their grief was profound because that little boy would no longer interact in their life again. So one needs to be aware of, do we make these decisions? So as I talked with this family, I said, no, you're not taking his life. The disease has ravished his body. He is dying a natural death. All the machines were doing was keeping his lungs inflated, the blood circulating. That would not happen, and he would never return to living what we would call a natural, normal life. So, I've been with people as they've taken their last breath, and I really believe it's one of the most sacred moments you will ever encounter. And I remember being with this man, and we made the decision. The nursing staff said, "Could you give us a few minutes? We'll remove some of these, apparatus." And we went in, he was still breathing on his own, but actually things started to slow down. And so we decided, he used to sing in the church choir, then later in a worship team. He had a beautiful voice. And the family said, "We want to sing some of the songs, hymns or praise songs or worship songs." And we sang a few. I read some scripture, and I prayed with him and committed him to God. And then everything just went still. And then we just had time together. And that was an amazing way to be able to have the family say goodbye. Now, one of the things we want to look at is the fact that we are seeing this happen more and more with the area of euthanasia. So I want to give you a little bit of background and some of the criteria, because a lot of this has come out of the Netherlands. At one time, the Netherlands was the most, quote-unquote, progressive country in the world for active euthanasia. So what happened was this. There was a doctor who in the I'm just trying to look at my notes to get the exact date. It was in the mid-1970s. His mother was really ill, and he gave her a lethal injection at her request. In 1993, the law in the Netherlands was changed, and it had to meet these following guidelines if someone was going to be euthanized. The first one is this: the person must be terminally ill, and that person had to be suffering, it was almost unbearable, but they had to request it. It couldn't just be done. So they're terminally ill, they know they're dying, they're suffering a lot, and they have made the request. The second thing is this: there is no other form of treatment that is available. And the third thing is this: they couldn't just immediately do it. There was a period of time where the patient had to reconsider and think about the request that they had actually made. Because sometimes in the spur of the moment, when you're in a terrible position, you can make decisions that are just emotionally based, and then later on you may think, oh, I don't want to do that, right? So that had to be over a period of time. And then the fourth thing is this: that the physician could not perform this act of euthanasia until they had consulted another physician independent of the case that was before them. Now, in the year 1993, they performed 6,000 acts of what we now call MAID. And they legally assisted, or legalized rather, physician-assisted suicide, which was known as PAS. Now, since that time, Canada has become involved in this program. And the program that we have is called MAID. Now, MAID was instituted, as you see, in 2016. So we have had MAID available for the last decade. This year alone, approximately 24,000 Canadians will die by MAID. Last year it was under 23,000, and the numbers keep growing exponentially. And so this was granted in 2016. Now, things have changed over the years, but let me say this: Canada has become the most liberal country in the world providing medical assistance in dying. Now, the question is this: who is eligible to receive this type of assistance? Well, the first thing is this: you must be 18 years of age and older. Now, they are giving some consideration, and I don't think it's going to go through because I'll talk about what's to come, but they were talking about having what they called mature minors be able to make those decisions. I don't think this is going to go through. In one of my classes where I was teaching, I had a psychiatrist in the class, and I said to the class, I'm not really sure what a mature minor is. And he said, well, let me tell you. He said, I know, because I've worked in this field. It's someone who's at least 12 years old. Now, can you imagine a young person making that kind of a life-changing decision? I think this is where the medical people and the legislators are realizing this is becoming, at least in my opinion, rather foolish and dangerous, to say the least. So you must be at least 18 years of age. You must be capable of making your own health care decisions. So you have to be able to speak for yourself. Now, this is the key phrase that is used over and over again in medical assistance in dying. You must have a grievous, that's the first word, irremediable condition. It can't change. It is very serious. It is not going to change, except it's going to get worse. So that means the patient has a serious, incurable disease or disability, and they are in an advanced state of decline. So they see themselves going downhill over and over again. And they are suffering greatly, physically and psychologically. Both of those are together. And that's caused by the disease or illness that they have, and they find it to be intolerable. And natural death is reasonably in the foreseeable future. Like they don't have long to live. The third part about it is this. The patient has to make the request. It is not to be suggested to you. The patient has to make the request. And they have to give informed consent to medical assistance in dying after they have been informed that there are other means of care to relieve their suffering, which could include palliative care. Now, the word palliative just means to comfort. And there are many hospices available, but not enough. And how do we provide palliative care? Well, I don't know if you're aware of this, but palliative care can actually be done in your home. You can actually get palliative care from the moment you have a terminal diagnosis. It just means we're going to provide comfort for you along the journey, and the comfort will change as your disease progresses. It could also include palliative sedation, so that if you are in great pain, they can, you would not be conscious of the pain. So I'm going to talk about palliative sedation a little bit more when we get to people wanting MAID, because there's a bit of a contest there between palliative sedation and having MAID itself. So those are some of the criteria originally in terms of who was eligible. Now, they have to make an assessment. So who is capable of making the assessment when the patient makes the request? Well, first of all, it has to be diagnosed by a physician. And secondly, there had to be a second physician that would concur with this diagnosis and this form of treatment. Then the patient must be able to fill out a written request, and that request is signed by 2 independent witnesses. So, for example, the witness can't be a beneficiary to your will. Good safeguard, right? The witness is not to be someone who is providing your health care. And the witness must be at least 18 years of age. Now, all they're saying is this: if they ask you to be a witness, it doesn't mean you agree with what they want to do. It just means you are witnessing that this is their signature on this document. Now, the question is this: who can assist in this procedure? Initially, it was only a physician or a nurse practitioner. Now they've extended it to even allow, in some cases, pharmacists to be able to assist. And that is generally done through a drug injection. Now, when they do MAID, there are 4 vials that they actually use. The first one kind of puts you into a relaxed state, then you move into a more sleepy state, and then you're comatose, and then the final injection ceases all activity within your body. That's one way. Someone can administer it to you. It can also now be a family member if you give consent, has to be your consent, that they are able to do it. The other way is this, that the drug can be administered by yourself. Obviously, that would be an oral drug that you would take, Or if you're competent enough, I suppose, you could do an injection. But the family member can only be involved if you specifically make that request and if they are prepared to do it. Now the fourth question is this. Where can it take place? Well, there are a number of places where this can actually occur. If they are in a hospital and they provide MAID, they can do it there. Now let me tell you this, that in Canada, the Roman Catholic hospitals will not perform MAID. So if you see a hospital like St. Joseph's, right? That's the Roman Catholic hospital. Even though it receives provincial funding, they will not perform MAID, even as they will not perform abortions, unless it happens to be a therapeutic one that it is required. My son is a trauma doctor in Hamilton, and one of the hospitals he works in is St. Joe's, and he has said to me, even though it is run by an order, I think it's the Grey Nuns, they were originally in charge. Now it's run by the province, but they have this religious orientation. They will not perform MAID. It could be in some long-term care homes where they will provide that facility. What we find is that generally in hospice or palliative care facilities, they are quite against MAID. However, they have permission to do it. You can also have MAID done in your own home if you request. So if you have a physician who goes there. Now there's a doctor in British Columbia. She was originally, I think, an obstetrician gynecologist. All she does now is MAID. And she will travel to people's setting, their home, and actually administer, I was going to call it the final rite, but this final act of life, which will bring death. Now here's the new one. There are actually some funeral homes that have set aside a room for MAID to be accomplished in their facility. So I guess you can move from there to the embalming room to the chapel. It's sort of like what I call one-stop shopping. Now there's not a lot of funeral homes doing that, but why do they do it? Obviously they've been requested. Obviously it's going to bring them some financial resources to do it. And in the end, that does become a business. That some people will be able to provide that service for people who actually request it. Now, what if you are someone who is in the medical field, like a physician or a practical nurse who is able to provide MAID? What if you conscientiously object to doing this? Now, you are not required, because of your religious or moral beliefs, to actively engage in MAID. However, and this is what's causing a lot of controversy, physicians who will not perform MAID are expected to help you find a physician or the hotline number where you can find resources that will enable you to complete that requirement. Now, some people are saying, I don't want to even pass on the name of another doctor who performs MAID because I don't want to be complicit in this in any shape or form. Now, I know that there's an organization called CMDS, and there's a similar one in the States, and then there's another one called I think it's called EMS. CMDS stands for Christian Medical and Dental Society. The other one is the Evangelical Medical Society, EMS, I think it is called. They are actively working with lawyers to deal with some of these issues, because I have met many doctors who say, I don't want to even refer people. If they want to do it, they can find it on their own. Well, it's not that hard to find out. There's a government hotline. You just Google it in, and you will find where the sources are for yourself. Now, in the Canadian law that exists at the present time, there are a number of safeguards that were put into place. That when you are making this request, there must be 2 independent witnesses who will sign that you have actually made this request. You are also expected to have 2 independent medical opinions. So that it could be your physician who is working with you, but then it has to be another physician who is independent of the case. Initially, there had to be a 10-day waiting period from the time you made the initial request until the time when the act was performed, so that it wasn't a big emotional decision that you had actually made, but that you had had time to think it through more clearly. When you make the request for MAID, you are also to be informed that there are other options, such as palliative care. And just before MAID was performed, on that day, you were required to express your consent to have the act go through. Now that part has changed a little bit, and I'll show you how it has changed in a few moments. Now the interesting one is this. There are a number of people who are not being informed that there are other options. In fact, in some hospitals, some of the staff have come in and said, we are a MAID facility and we can offer this to you. You see, you're supposed to request it. Now they're telling you this. And sometimes people are thinking, well, you know, it's costing a lot of money to keep me here in this facility. This money can be freed up, whatever, and it can help people who are going to have need of a hospital bed or whatever it's going to be. And so sometimes there can be a bit of guilt laid on some of these situations that are before us. Now, there are some new guidelines that developed about 5 years ago. And part of this was that people wanted to make a request to have MAID, even though their death was not in the foreseeable future. Originally, it was supposed to be within a short framework of time. But some people have a diagnosis that is terminal, but they could live a year, 2 years, maybe 3 years, whatever it's going to be. So what they did was you could write out your consent. If I get to this stage, I want to be able to have MAID performed. Now what they put in was you no longer have to wait for the 10-day period. It can be shorter than that. You could, I'm exaggerating a little bit, but you could almost request MAID today and be dead tomorrow. It is not much longer. It depends upon how readily available the facilities are and the decisions that have been made. What they used to have was you could make this long-term request, but you had to wait almost 3 months, a period of 90 days. And they shortened it to make way if your capacity physically and mentally had begun to deteriorate very quickly. Now this happened, if you notice there's a little statement at the bottom by a woman called Audrey Parker. And this has become known as Audrey's Law. Audrey Parker is from the Maritimes, and she was a woman who was suffering from a very difficult illness. It was irreversible. She knew that she was going to be dying, and she had made a request for MAID. And but at that time, the law required that before MAID could be administered, you had to give consent before the act took place. Well, she had a form of dementia as a result of this disease, and she could not legally consent, and therefore they could not perform MAID just before it happened. The family fought it. Audrey Parker died. The family fought it, and the government has changed it, that if you write out your consent for MAID when you are mentally competent, it is there, it is witnessed, it is done. And you now move to this final stage and you are no longer mentally competent, They can't ask you that question at the end. And even if they say to you, okay, Audrey, we're going to do MAID today, and she might go like this, they will still go ahead with MAID because you made the decision when you were mentally competent. It will not be reversed. That's where the law sits today. So we need to be aware that the agreement to waive the final consent will be invalid if the person, after being, having lost decision-making capacity, demonstrates by refusal of words, reflexes, or gestures. So once you've made that and it's signed, it's not going to be reversed. Now you can reverse it when you are mentally competent and say, I do not wish to have MAID, and then it will all cease. But the key is you have to be mentally competent. You can't have Alzheimer's, you can't have a form of dementia, things of that nature. You could be in a coma, and they are going to go ahead with that decision. Now, what are the things to come? Well, this is one of the big questions that has been dealt with, and it was supposed to be coming in March 2027. Just before coming here, I went and did a little research to see if this is still in place. But what they were thinking about is doing this, that if you suffered immense pain from psychological struggles or illness, let's say you're in a severe depression, you're schizophrenic, you're bipolar, whatever it's going to be, and you say, I can't live with this anymore. I want to end my life. They were considering making that a reality as one of the criteria that MAID could be administered to you. And what I have read recently is this was like last week, that the lawmakers are reticent to make any kind of a decision in that regard because there's not enough research to begin to support that argument. So I'm very grateful that they're doing that. And can you imagine? I've worked with people, as a psychotherapist, I worked with people who had struggled with depression. But there's all kinds of depression, and much of it can be helped with proper medication. Some depression is just related to loss and grief, and we can help them walk through their grief. But can you imagine someone in a depressed state saying, I just don't want to live anymore? And they go through that process. We're on a very slippery slope. Then who next do we think does not deserve to live? And how are we going to make some of those decisions? Well, that's a little bit of the background. I'm going to move on quickly because our time is going, and I want to leave time for questions. So I want to talk about in support of MAID, or euthanasia. These are the arguments people will put forward, and I'm only giving you a few. There could be many more that we could deal with. The first is we guard our freedom and liberty. We want to be able to make our right decisions. And people say, I have the right over my life. I have the right to live, the right to die, as long as it doesn't hurt anybody else. The next big one is the loss of human dignity. In other words, I see my body deteriorating. I don't want to be a burden to others who have to help me. My dignity is everything to me, and I don't want to go through life like this. And that's part of their reason for it. The other one is this. I am suffering, and I'm sure you've heard this. You know, if our pet at home was suffering, we would put it down, right? Except a pet doesn't have a soul. A pet is not made in the image of God. A pet is a pet. And they say, well, we show more kindness to the animals by putting them out of their misery than letting us suffer what we are experiencing here. That's a huge one that people throw up all the time. And then I would like to have a peaceful death. In other words, I want to have a death according to my liking. In other words, I am negotiating with death itself as to when and where it will take place. But there are some arguments against euthanasia that I think as Christians we need to understand and at least be somewhat familiar with. The first one is this: do we believe that God is sovereign and that He alone has the right over life and death? 1 Corinthians 6, verse 20 says this: "You are not your own. You were bought with a price. Therefore, glorify God in your body. How I live and how I die, does that bring glory to God? And do I as a Christian believe that I can do whatever I want with this being that God has given to me, this physical being included? No, this belongs to God. And I have to care for this and treat it in a way that brings honor and glory to God. And by saying I don't have the right over life and death, I am saying, God, you alone have that right. And I will trust my life into your care. And in your timing, I will trust. And I know that you are with me because you are the sovereign God of heaven and earth. The second thing is this: do we believe in the sanctity of life? I think we all say, yes, we do. Does that include, I don't have the right to destroy this life that God has given to me, or to participate in the destruction of another person's life or the ending of that life? And then there is, for some, what we call the wedge argument. It's like putting a wedge in the door. You know, you're going to open it up a little bit more. If we talk about we can end the life of those who are incurably ill, what about other people? The social deviant, should they be eradicated? What about people who have disabilities? Now, there is a philosopher out of Princeton University. His name is Peter Singer. And Peter Singer was arguing that anyone, even with disabilities, has become a drain on life and they should be euthanized. And he was putting all kinds of arguments out there until his mother suffered from Alzheimer's and he saw her deteriorating before his eyes. But he could not come to the place where he would say, I need to have my mother's life ended. He did everything he could to maintain a quality of life for his mother until she died. You see, it's one thing to have all these great theoretical ideas, but then when the rubber hits the road, how are you going to deal with it? And then there is the possibility of abuse. Are we giving too much discretion to people in the medical profession? There was a woman near the Woodstock, Ontario, a few years ago. She had a number of elderly patients, and she decided that they would be better off not alive. And she injected lethal dosages to 8 of them, and they died. Now, that's before MAID became prevalent or permissible, and she's in the big house these days, spending her days there, right? Today, it would be considered a legal right if the patient had requested it. And then is there a possibility that, and this might be very slight, but it is a thing to consider, there's a wrong diagnosis? Or is there another treatment on the horizon that might enable this person to live fairly well? And then, does it undermine the whole goal of medicine, which is life and health and not death itself? So, we've come to what is called physician-assisted suicide. Now, what is it? This is an intentional act on the part of a doctor which is aimed at causing the death of a patient. Now, there are 2 ways that this can happen. The physician may provide the prescription and the patient would self-administer the drug. And as I mentioned earlier, that this would be taken generally orally. This was traditionally known as PAS, physician-assisted suicide. You know what the term is today? MAID. It sounds nicer, right? Medical assistance in dying. The other way is that it would be done directly, that the physician or the nurse physician assistant would administer the drug, and usually with an IV. It would be an IV because there's 4 vials that actually go into the person, and this was traditionally known as euthanasia. Now, what we have discovered is this: why are people opting for MAID? Now, there is a Christian doctor in Toronto, Ewan Golding. He is also an elder in Grace Presbyterian Church in Toronto. He is well informed theologically. He is also a critical care physician, so he deals with this every single day. So he comes at it from a medical point of view, and he comes at it from a Christian perspective. And they've done some research out of the University of Toronto. And here's what they discovered. For more than 90% of the people who request MAID, 90%, it's this sense of the loss of autonomy. In other words, I am no longer in control of my life and circumstances as I wanted to be at some point in time. Now, I'll give you an illustration. I shouldn't give too many illustrations because I'm not going to get done in time, but I'm going to give this one. And it happened in one of the big hospitals in Toronto. It'll remain anonymous. One of the staff one of the chaplains there told me a woman was in her early 90s, sharp as a tack, but she couldn't move quickly like she used to. Well, you're 90-some years old. What do you expect, right? And she couldn't prepare Sunday dinner the way she liked for her family anymore. She requested MAID. It was granted. There's this loss of autonomy. 80% said, I'm no longer able to engage in enjoyable activities, and I am afraid of losing my dignity, how I appear. And I don't want to be a burden on my family. Less than 30% of these people said there is inadequate pain control. Now, the reality was a very small percentage truly had inadequate pain control. Here's what we need to think about. They could have provided, but some don't want it, what is called palliative sedation. And I'm going to explain that in a minute. So, here's what they have found, that the majority who request MAID in Canada are wealthy, they tend to be white, and tend to be non-religious. So this study was done about 3 years ago, and some of the statistics might change a little bit, but that is the reality. Now, why do we do this, and how do we look at it? And I want to suggest this, and this argument has been so helpful for me to understand MAID, and it's on the issue of how do we value people. Now, I think everyone would agree, people matter. Even those who advocate for MAID, you would find out they generally care for people, and they think what they are doing is a caring act. But let me tell you this, there are 2 types of value, and I would suggest that many who practice MAID don't know the 2, they know 1. The first one is this, what we call extrinsic value. This value, my value, comes from what I am able to do. And therefore, if I'm able to do things, I am of value. So let me give you a very practical illustration. Let's say you own a bicycle. You can ride it. It gets you around. You can move around the campground here. If you don't want it anymore, you could sell it and you could make some money. So you got, this bicycle has value. But it only has extrinsic value. Why? It's based on its usefulness. It can get you around. If my bicycle breaks and no longer works, it has no value. The second thing is, this bicycle is replaceable. I can get another one, right? And I can get around. I'm under no obligation to value that bicycle unless someone finds it valuable. Value comes from an outside source. I believe this bicycle is valuable. You might think, I don't think it is. And I can put a price on it. So value depends upon how useful it is and what I want to do with it. Now that's how a lot of people look at life. I can no longer do what I've been doing. What good am I anymore? Our grandfather, my brother and I, on my mother's side, he was a real estate broker. He had a little company just out of Ottawa. And he kept that company going till he was in his early 90s. And sometimes I would have to drive him to show a property because he was such a terrible driver. And I would get him to places. Then when he hung up his license, he said to me these words, and I've never forgotten it, years later, what good am I anymore? He couldn't do that job. What good am I? You see, it was based on extrinsic value. But there's another value, which is called intrinsic value. This refers to the value that comes from the thing itself. It comes from inside of who we are. So let me suggest this. Your value as a person is unconditional. It doesn't matter if you're smart. It doesn't matter if you're athletic. It doesn't matter if you are artistic. Your value is something far more significant. It comes from within. You are irreplaceable. Someone can't come and replace you because you are unique. No one else is like you. And you are priceless. That's why we can't buy and sell people. That's why slavery is anathema. So we recognize that it is wrong to treat people only if we look at their extrinsic value. Because people are priceless, irreplaceable, and they are made in the image of God. So that means I need to value myself. I can't make those decisions that say, I'm no longer good, I'm no longer of value. You were bought with a price. Therefore, glorify God with your body. Now, the focus here is understanding that people are created in the image of God. That means you have reason, you have learning, you have language, you have ingenuity. It's interesting, Jesus communicated caring for people that you are of value. And the royal commandment is this, that we talked about earlier. Love God with your heart, soul, mind, and strength, and your neighbor as yourself. And we become aware that God knows the needs that we have. He said, why are you so anxious about things? Don't you think I care about you? A little bird doesn't fall from the sky and I know about it. Aren't you much more value than those birds and the flowers of the field? I need to be reminded this is my value and my life belongs to God. I love this statement that comes from Romans 14:8. It says this, and if we live unto the Lord. And if we die unto the Lord. Therefore, whether we live or die, we are the Lord's. Now, last thing I'm going to talk about is this, and this is where I think we need to also take some steps, is that we learn to have advanced directives. And one of the things you can do is to go onto this website if you want, and you can write out a living will. So people will know what you want and the type of care that you want. So I have a living will. I've talked about it with my wife. I've talked about it with my children. They actually have a copy of the living will. And they know the steps that I want to take. So if I'm in a situation where I'm not able to communicate, they will speak on my behalf. And this is why you need to have some advanced directives. I could do a whole seminar on developing a living will and advanced directives, but I realize we only got 2-3 minutes left, and I want to open up for some questions. But if you don't have a living will, this is what is going to happen. And it's called an SDM. Stands for Substitutionary Decision Maker. Now, there is an order for having a substitution decision maker. One of the ones would be if you have a guardian, who is this person who's going to look after you? Or if that's not available, maybe the attorney that you have actually appointed to make decisions for you. If you don't have that, the government of Ontario, I'm just speaking of Ontario, has a representative appointed by the board called Consent and Capacity. Now, the Consent and Capacity Board is made up of 3 people: a lawyer, a physician, usually a psychiatrist, and a member of the community. And they will make a decision quite quickly. They will hear your case, and a decision will be made no longer than 7 days. So you might have to wait, right? That might not be too pleasant if you're in a hurry. But there is a group who will decide what's going to happen. Or if there's conflict, this board will step in if things are not clearly delineated. Now, the first person who we usually know about and be asked to make consent for your care or treatment for your advanced directives will be your spouse or your partner. If they're not, it could also be your child, if they are at least 16 years of age and older. So it's pretty tough if a 16-year-old has to make a decision and they don't even know what you want, right? Or it could be your parent if they are still alive. If you have a child and you're in a relationship where you are now split up, the parent with the right of access only makes the decision for that child. Because the law says the custodial parent is ahead of the non-custodial parent in terms of making decision. If they're not available, it could be a brother or sister or anyone who is related to you by blood or marriage or even adoption. And then if none of this is available, then it's the Office of the Public Guardian and Trustee. A friend of mine, he goes to the same church. He has that office. He works out of Hamilton. And he said he has to make these decisions every day because people have never talked to their families, have never made decisions about how they want to be cared for and what they want done. So a living will deals with everything up till the moment you die. Your last will and testament deals with everything from death to the next, getting rid of your property, your assets. So there are 2 separate things. All right, it's 10:30. If you need to go, feel free to split. I'm going to take some, I can hang on for a while. If you have any questions or comments, I'll try to answer them and see what's going to happen. So any questions, anything you want to raise? Yes?
I had a question about, you were talking about the slippery slope.
Sorry, Bill, which?
About the slippery slope.
Oh, the slippery slope, yes.
Like I remember in like the late 90s, the early 2000s, when we were debating about same-sex marriage. And
Right.
The sermons and everything that we heard was, this is going to be a slippery slope. You let this happen, it's going to open up this can of worms and this, and we're living that now. We're living that slippery slope. We're seeing everything under the sun here. I just don't have enough imagination here. What's the slippery slope for this?
Okay, the slippery slope could be that we are going to allow people with mental challenges to be euthanized. The slippery slope could go to World War II with Germany. You get rid of certain ethnic groups, whether they're gypsies, whether they're Jews, if you have a color skin that's different from theirs, if your eyes are not necessarily blue, a certain religious affiliation, who knows where it could go. We say it could never happen. Never say never. I think what has to happen is that you and I as citizens need to be actively involved even politically, even if it means, at the very least, talking to your member of parliament provincially or talking to your member of parliament federally. So when some of these things come up, I actually wrote to my member. I wrote to the Prime Minister. I got a form letter back with a dead bug on it. I didn't even get that back from the Prime Minister at the time, who was Mr. Trudeau. My member of Parliament happens to be a very committed Christian in my area, and I can tell you this, the Christian parliamentarians try to speak very vocally from a Christian point of view. But I think that's why we need to make your voice known. Let's face it, I don't want to get into the LGBTQ issue, but they started as a very small group, but they became vocal. And that's their agenda. So, you know, the old saying, the squeaking wheel gets the oil. So we need to be aware of that. So who knows where it's going to go? Then the other question would be, what about people with disabilities? Maybe they don't have cognitive ability to decide. And people might say, well, maybe yes. So this is scary, but I read it. I believe it is true. There was a member in the Quebec government who was proposing the idea that if you had a child with mental disabilities, up until age 1, you could ask for MAID to be performed on that child. Now, it didn't go anywhere, but that tells you that is some of the thinking that exists in some people's minds.
See, I can see that being more of what would happen, less so than the ethnic cleansing sort of side of it, because I think those people would be freaking out in the street if they're loud about what's happening.
Yeah.
The way that the media is compared to World War II is very different now.
Yeah.
But I just, like, that would be horrible to think that we evolved as a society that could start saying, well, this person can't say no, so we're going to request MAID for them, like either as a baby or a disabled person or something. But,
Question here, then we'll go here. Yes.
Well, it's kind of a continuation of that with a person with disability or I'll call it a dependent that can't make their own decision.
Right.
So how does that work?
Well, that's why I think that if you were the guardian, so for example, our youngest brother had Down syndrome, and I was made his legal guardian near the end of his life, and so I had to make some decisions. So I wanted to have adequate medical care, but we had, those days it was called a DNR, do not resuscitate. A lot of people are changing that language to no longer DNR, but it's AND. So DNR stands for do not resuscitate, AND stands for allow natural death. And so I said we had guidelines down that if something happened, his heart failed or whatever, then we wanted a certain type of care done. He could come back to living the normal life that he knew. He's never going to be to the full wholeness mentally that, say, I am, but he could have a normal life that he knew. But if not, then we would not perform all these extraordinary measures. And actually that happened. They lost the DNR thing. They worked on him for 25 minutes. His heart had stopped, and they brought him back. I said, so what's the brain function? They said, it's nothing. It's flatlined. And then I said to the doctor, what is your recommendation? And I knew what I was going to recommend. I just want to know what he was thinking. And he said, I think we commit your brother to the care of God. I said, I agree. So we removed the life supports. He continued to breathe. He was not conscious for about maybe a half an hour. And then everything flatlined. So I have to, if I am the primary decision maker, I have to think about what are the basics of my ethics. What kind of care would I want? What is realistic? And how does my faith address that? So we got to think it through. So it's intrinsic value. In the sense of extrinsic value, what would I say? Well, he can't do this, he can't do that, can't do the other. What's his intrinsic value? Made in the image of God. Invaluable, irreplaceable, Yes?
I just wondered if you could say a word more about sedation and what
Okay.
the answer is like, because I had a good friend that struggled through a couple of different types of cancer over time and bouts, and then eventually it wasn't gonna be very long. I don't know if she got made in the end, but I know her husband told me they'd done the paperwork in the final stages.
Right.
Just in case, because it was brain and lungs and other areas.
Right.
The breathing became so, like, so much anxiety and fear and discomfort. So,
Right.
but I'm wondering about, like, with palliative sedation for someone that's just like dealing with shortness of breath or even the fear that I'm not gonna be able to breathe, you know, take away that suffering and instead of pain.
Sure. So it goes back to the famous theologian called Thomas Aquinas, and I won't get into the whole thing, but it's called the doctrine of double effect. And it applies to many things. So the idea is, what is your intention in terms of what you are doing? So let's say you're in a situation and I want to relieve you of pain. And my intention is I will put you to death. I will perform MAID. You will be out of pain. That's my motivation. But my other motivation might be, I don't want to put you to death, but I want to give you enough pain medication that it will alleviate the pain. You might be in a palliative sedation, and you might actually die. But that's not my intention. My intention is to relieve your pain. And so that's why I would say that palliative sedation would be an option for a Christian. You're not going to be in pain, you're not going to be anxious, you might not be able to communicate, but I haven't taken your life. Now it's possible that the bolus of morphine might put you over and you die. But that happens every time you go in for an operation. You sign a waiver, right? The doctor doesn't want you to die in the surgery, but you might happen to die, but that's not the intent. So it goes back to, what is my intent? Yeah.
And the palliative sedation would provide that comfort.
Correct.
Take away anxiety.
Exactly.
Right.
Yes. I think there's a question here.
Somebody was asking about the slippery slope.
Yes, slippery slope.
And I can just see this, like, as in the LGBTQ, it becoming a celebratory practice, where they make an event around it, and they bring the person to the place of family or there, and they celebrate this, and then they go and have the injection, or go and have the medication and die, and it's part of it.
Yeah.
My son is a funeral director, and he's known that this has happened in 3 occasions, and then the body comes to the funeral home.
Right.
But that's gonna be a norm, especially in a non-Christian field, that it says, okay, this is wonderful. We can surround him with family and say our goodbyes and release him.
Yeah, sometimes we're trying to put a positive spin on it, and people will do that. The other thing which is coming out of the studies now is that there is a lot of emotional upheaval years later by the family that remains. They're feeling guilty, they're feeling angry, some are in serious depression because they thought, this was the ending of life for my loved one, we had consented to it. Now here's the question I get asked, and I just wrote a position paper. I'm a Presbyterian, but I wrote it for the Pentecostals Assembly of Canada, so it must be fairly generic. But I was asked to write a position paper on some of this, and then I was asked to write a paper on practical pastoral application. And part of it came down to this: what would you do as a pastor? So the first thing I would do is this: I would meet with the person and to see, why are they requesting it? And it could be, I don't want to be burdened, I'm anxious with all that, and find out there could be a number of other underlying scenarios that are there. Second thing would be that I would try to convince them of their value of life. And if all that failed, and they decided to go ahead with MAID, on the day of MAID, I would gather with that person, I would pray with them, I would read scripture. However, I would not be present when the actual act was done, because I don't want my presence to be interpreted as consenting to what they are doing, because it goes against my belief. I would then step away, and when the act had been completed, then I'd probably meet with the family, because I know they're going to have to deal with a lot of stuff. So I know some pastors, I've been talking about this, some have gone into the actual act and have been there when the person did die. I just don't want it to be perceived that I am consenting. I want to provide kind, compassionate care, but I want to remain true to my own convictions as well. But doing it in a way that I just simply say, I will step away when this happens because this is not my belief, but I will continue to support your family and you'll see where that goes.
Do nursing homes opt to not accept MAID?
Nursing homes?
Yes.
I'm sure